Finally, to conclude this session, we will thoroughly and comprehensively discuss the various important, necessary, and critical medications that we need to consider for patients with hyperuricemia or gout. In patients treated with allopurinol, we must pay special attention to azathioprine, salicylates, decumarins, and cyclosporine. Regarding azathioprine, this is because both hinder the process of the biochemical metabolism of antioxidase in the human body, and the recommendation in this case is therefore not to use both drugs such as these at the same time. Regarding salicylates, the type of interaction they have is due to the increased renal elimination of oxypurinol, which is a metabolite of allopurinol. As a result, it would reduce the effectiveness of allopurinol, and no specific recommendation has been established in the event of an interaction between the two drugs. Regarding allopurinol with coumarin anticoagulants, a metabolic interaction occurs that increases the anticoagulant effect, but it is not recommended to avoid using both drugs together. The recommendation in this case is to monitor anticoagulation levels. If necessary, allopurinol could be used. And regarding cyclosporine, there is an increase in its plasma levels, again due to an interaction, in this case at the tubular level. Renan. Cyclosporine toxicity may occur, but once again, the recommendation is to monitor, not to discontinue. Now moving on to talk about febuxostat. Again, caution is advised with azathioprine due to its interaction with xanthine oxidase inhibitors. And just like in the previous section, it is recommended not to use the drugs concomitantly. Febuxostat also interacts with NSAIDs. The type of interaction involves a reduction in the elimination of febuxostat due to competitive inhibition of glucuronidation. There are no clinical consequences, and no dose adjustment is necessary. It also interacts with antacids by reducing the absorption of febuxostat. And again, no adjustment is necessary, and there are no clinical consequences. Regarding benzbromarone, it interacts with hepatotoxic drugs, mainly anti-tuberculosis medications. And in this case, it is indeed recommended to avoid its use concomitantly with pyrazinamide. However, salicylates can be used without any specific recommendation, although they may reduce its effectiveness. And regarding the combination with coumarin anticoagulants, it is recommended, as previously mentioned, to monitor anticoagulation levels, but discontinuation is not advised of the same. Now we move on to talk about colchicine, with or without dicycloverine, which would be Colchimax. On one hand, we have the interactions caused by colchicine with agents, both anti-infectives and tacrolimus, which are due to a metabolic interaction that inhibits the elimination of colchicine, since both act through the same cytochrome. This can lead to increased toxicity from colchicine, and they recommend taking extra precautions, but they do not recommend discontinuing the medications. With cyclosporine A, there is also an interaction due to an increase in plasma levels of colchicine caused by inhibition of the glycoprotein P, and again, it is recommended to take extra precautions, but not to discontinue the medications. Regarding the combination of colchicine with lipid-lowering agents, it should be noted that there is an increased risk of myotoxicity, which means that both myopathy and rhabdomyolysis may occur, and we must once again take extra precautions with this type of patient. In the case of using Colchimax, we must keep in mind that in addition to the effects previously mentioned, there may be interactions with anticholinergic agents listed on the slide, which can lead to an enhanced anticholinergic effect of dicycloverine. And a risk of anticholinergic syndrome, we must once again take extra precautions in the event of interactions with these drugs, but they can be used. And finally, to conclude, we need to be aware of those drugs that increase uricemia, especially in cases where, despite proper treatment and high medication doses, we are unable to sufficiently lower uric acid levels as expected. The drugs that increase uricemia levels are mainly acidic diuretics and those of the ASAM type, such as certain types of medications. Cyclosporine and tacrolimus also play a significant role, as do pyrazinamide and ethambutol, as well as lead and teriparatide, among others. Those drugs which are known to cause a notable increase in uricemia levels, and therefore it is important to consider their use in clinical practice, especially in cases where we are unable to lower uricemia to the desired level to achieve optimal outcomes in patients with elevated uricemia. And then there are those drugs that play a practically residual role. Thank you. These include acetylsalicylic acid, niacin, and didanosine. Those drugs are also known to increase uricemia levels, but in this case the increase is practically negligible. Still, it's something to keep in mind as well.